And our first talk is called Lung Cancer Stigma, Is It Real? And we're so excited to have Dr. Joan Schiller, who I know you heard about last night and this morning. She's a widely published and internationally recognized for her work in lung cancer clinical research. She's a professor in the Department of Medicine, section of Hematology Oncology at the University of Virginia. Welcome, Dr. Schiller.
Thank you all. Thank you for that very warm introduction and for inviting me here. Lung cancer and stigma is a subject that's near and dear to my heart, which is one reason I wanted to come. But the other reason was just to reacquaint with old friends that we go back quite a way and to make new ones. I am so impressed with everything that your group has done. It's amazing how much it's grown since I last was here, so congratulations on that. There we go. So I am a medical oncologist. So what that means, one of my passions is trying to find better treatments for lung cancer. I am not a psychologist, unlike Dr. Williamson, who will be coming up. So I'm just speaking as a neophyte, so to speak, to this field. But the reason I got into it was because so many of my patients, it became very clear very early on, weren't really advocating for themselves, and they were embarrassed, or their family was embarrassed or something, and that just wasn't fair. I mean, as you folks well know, lung cancer patients are just as wonderful, if not more wonderful, than most other types of cancer patients, and it just wasn't fair. They weren't getting the same treatment. And so stigma. So if you look at the Cambridge Dictionary, it's a strong lack of respect for a person or a group of people, or a bad opinion of them because they have done something society does not approve of. If you ask Siri on your Macintosh, it's a mark of disgrace associated with a particular circumstance, quality, or person. So this is what I'd like to talk with you about today. First of all, is the stigma around lung cancer real? Does it really happen? And can we measure it and document it? Why does it happen? What are the consequences of stigmatizing lung cancer? And can we reduce the stigma associated around lung cancer? So as I think Amy pointed out earlier, I got involved with something called the Lung Cancer Project. And what that was a project that was primarily funded by Genentech to look at the whole aspect of stigma, and in particular to be able to identify it quantitatively. This was supported by a number of different organizations, and it consisted of three main points. Now let me see if I can do there we go. Three main points, one of which, so first of all, it was online. It's still online if you guys want to take it. It's very interesting to take. The lungcancerproject.org. In 2012, when we did this the first time, there were there were over 1,700 people who participated, and they were asked about three things. One was their general knowledge about lung cancer, and then what psychologists call explicit associations. And really what that is conscious associations about cancer. Two types, one descriptive, and what that means, cancer patients are tall, cancer patients are redheaded or whatever, versus normative, meaning cancer patients ought to be smart, or cancer patients ought to be right-handed or something. And then the second was what they call implicit associations, which is really unconscious associations, and we'll get into that in a second. So in 2012, when we first did this study, you can see this is the demographics. Like I said, over 1,700 participants, most were women. The vast majority, 1,600, were not healthcare providers, but 142 were. 677 had either lived with or taken care of a cancer patient, and of the 240 some patients who had some type of cancer, 78 actually had lung cancer. So again, focusing on the explicit associations, they were descriptive, meaning people with some type of cancer, and in this we asked either breast cancer or lung cancer. So people with lung cancer are ashamed about their disease, or people with breast cancer are embarrassed to tell others about their disease. So they were asking very specifically what the participant thought. Normative was, in my opinion, people with lung cancer ought to be ashamed about their disease, or people with breast cancer ought to be embarrassed to tell others about their disease. And so the results for this aspect of the study, the explicit aspect, and it doesn't come out, the different bars don't really come out here, but they were asked, in my opinion, lung cancer ought to be, and given negative words. 1 is strongly disagree, and 6 is strongly agree. This is breast cancer, so you can see, in my opinion, people with breast cancer ought to be ashamed or embarrassed or whatever. You can see mostly 1s and 2s for breast cancer. For lung cancer, we are now starting to move over, that there are fewer patients who strongly disagree and more participants who agree. And here are the descriptive attitudes, meaning people with lung cancer are ashamed, and here's lung cancer, here's breast cancer. You can see here that the majority of these participants were in the anywhere from strongly disagree with negative statements about breast cancer. Here's lung cancer, and here most of them are in the middle. They neither agree or disagree when it comes to lung cancer. And then there was this very interesting aspect of the study about implicit attitudes. So this is something, these are unconscious beliefs. And my understanding is, in the psychology word, this is a validated method, often used to figure out if people are prejudiced about a particular demographic, for example. And what it is, it's a study that's done, and it's all about the reaction time. And it's the reaction time to this. So this is on a computer. You are shown, in this case, a picture of a lung tumor. And then you are asked to press the letter E, or sorry, I think it's E, or the letter I. And the letter E here, despair or breast cancer, and here, hope or lung cancer. So you're shown this picture and you have to press an E or an I. And then you are shown this picture of a breast tumor, and again, you have to press an E, despair or breast cancer, or an I, hope or lung cancer. Or you're given this picture, again a lung cancer. Now it's despair or lung cancer for the letter E, hope or breast cancer for the letter I. Or breast cancer, despair, E is despair or lung cancer, I is hope or breast cancer. So the idea here is that if you're looking over here, well, this is obviously a lung tumor, so you're going to press the letter I. The question is the word hope a distractor? Are you going to press the letter I any different here than you would do it here, where the letter E is despair or lung cancer, or the letter I is hope or breast cancer? It's only a fraction of a second difference, but that's what they're measuring. Do you press, does it take you a moment longer to press the correct I here versus E here? And it turns out the word, well, and then, let me go back a second. So in this particular example, the word is despair, but these are actually all the various words that were used. There were some good words, quote unquote, wonderful good, great, bad words, dreadful bad, hope words, despair words, shameful words, and something called suitable words. So they mixed up all these words. And here are the results. So again, the question is, do you press something a little bit slower if it's lung cancer associated with a good word versus lung cancer associated with a bad word? And the answer is yes. Now, it's not by much, but it's highly statistically significant. So what we're looking at here is the number of participants with implicit associations toward lung cancer and the words good or bad. So these are the number of participants who pressed lung cancer and good words a little faster than lung cancer and bad words. You can see the vast majority of participants here pressed lung cancer and bad words faster than they did lung cancer and good words. And the reverse was true for breast cancer and bad words and breast cancer and good words. This is another example with words indicating hope and despair. Again, these are the number of people who press lung cancer and hope button a little bit faster than those who press lung cancer and despair. And clearly everybody was in the lung cancer and despair part. Not only proving that there was a difference between how people felt about lung cancer and breast cancer, but also very importantly that we can quantitate it. So if you can measure it, then you can measure if you can change it. So, yes, lung cancer patients are stigmatized, and the question is why? And all sorts of various theories out there. This is the big one, of course, is that they did it to themselves, even though the vast majority of smokers started before they knew better, or when they, either because they were older and cigarettes were given free, or they're teenagers and rebellious and think they can quit at any time. The majority of smokers have tried to quit but can't because nicotine is so addicting. About half of all lung cancer patients, lung cancer occur in people who can't quit, either because they never started or because they already have. And let's face it, we have a double standard. We don't stigmatize people who didn't wear seatbelts in car accidents as much as we stigmatize lung cancer patients, right? Or stigmatize people with heart disease because they've eaten a lot of cholesterol or whatever, the way we stigmatize lung cancer patients. We do have a double standard, I think. Another reason for why there may be a stigma is this one, and that is the media. So the media launched in the 60s and 70s a big campaign to quit smoking. And it was very effective in terms of getting people to quit smoking, but I would think it had some unintended consequences. And that is, many of these messages were quote unquote hard hitting. Their goal was to arouse fear. And with that, one of the ways they did this, I think, was to stigmatize smoking-related illnesses. And that was by showing a lot of negative ads. And there's, I think, a real sense out there that the unintended consequence of this type of ad was to stigmatize lung cancer. Is stigmatization bad? Are there any consequences of it? And I think there the answer is definitely yes. One, I think, consequence, I'm not sure if it's a consequence or a cause, but is the difference in funding between lung cancer and some other types of cancers like breast cancer. This is a hard graph to read, but this is funding by the NIH, the National Institutes of Health. And what you can see here is that they fund approximately $13,000 per breast cancer death, compared to about $2,000 per lung cancer death. This is in 2015. Talk about a huge, huge difference, and how this impacts on the outcome of breast and lung cancer patients, I think, is a good question. The other way that stigmatization, I think, hurts, that has been proven, is about the timing of whether lung cancer patients, how long it takes them to seek health care. So this is a study that was done in Louisville, Kentucky, 94 patients. And what they did was they asked these 94 patients all sorts of stuff. such in addition to demographics and how long it took for them to seek medical help. They asked about smoking status and how much they trusted the healthcare system. And these are the results. So these are all the various things they asked about. But the only one that came out that influenced how long it took to seek healthcare was lung cancer stigma. Now, symptoms of stigma: guilt, regret, perceived blame, demoralization, again associated with delayed diagnosis, poor quality of life, poor patient and clinician communication, may result in reduced treatment adherence and heightened psychosocial distress. This was a study that was published by one of my former colleagues at University of Texas Southwestern, Heidi Heyman, in which she did a number of interviews to get a feel for, once again, the magnitude of the problem, and found that of all the people she interviewed, 95% felt some type of stigma, either from others, 62%, or they internalized their stigma, 60%, via self-blame, guilt, sharing, anger, regret. And then she looked at, well, again, she found that all groups, regardless of smoking status, felt some type of stigma, but that internalized stigma, anger, depression, was more common amongst current and recently quit smokers. And she found there were two ways for patients to deal with stigma. One was not a very good way, she called it maladaptive, and that was decreased disclosure, not talking to your clinician, not going to seek care, not talking to your family. And another one, which she felt is a much better way to deal with this, is adaptive methods, such as increased advocacy. So meaning that those patients who, instead of internalizing their stigma, got mad and did something about it, e.g. advocacy, were the ones that did better from a psychological standpoint. Now, one issue that I think the lung cancer community really struggles with, and I do not have a good answer to this, is the issue of lung cancer patients who are smokers or have smoked versus those who have never smoked. I think all lung cancer patients report experiencing stigma, such as the first question that nearly everybody gets asked is, did you smoke? And never smokers feel there's some guilt by association there. So there's a big tension between smokers and never smokers. Smokers maintain, it shouldn't matter if you smoked, no one deserves lung cancer, and that by highlighting that never smokers can get lung cancer too, that further stigmatizes smokers. Never smokers maintain that they are tainted with the stigma associated with smoking-induced lung cancer. And to point that out, they talk about the big discrepancy, for example, between support services for women with lung cancer versus women with breast cancer, huge discrepancy. And that they also maintain that showing the public that even never smokers can get lung cancer may put a less stigmatizing face on the disease. So this is a real tension that I don't have a good answer for, but I think the lung cancer community has to address in order to move on. So why does it matter about being stigmatized? Well, this is a study that we did and reported a couple years ago. And one of my colleagues, again at UT Southwestern, compared the rates of treatment for lung cancer by state with these patients' implicit associations about lung cancer by state, and found out that in states where cancer patients had to have their implicit scores with the terms despair and shameful, where those were more so, in those states, the lung cancer drug treatment rates were lower. So stronger negative implicit attitudes toward lung cancer and and stereotypes linking smoking with lung cancer was associated with fewer patients getting systemic treatment. A big reason why stigmatization matters. Another reason is the effect of stigmatization on screening. Again, this is by Heidi Heyman, and she looked at the uptake of other types of cancer screening and compared those with low-dose CT lung cancer screening. And I think we all know, found that when she published this a number of years ago, it was very low, only about 4%. Only 10% of screen-eligible patients even talked about it with their clinician. And when these patients were interviewed, they all reported stigma as a significant hindrance to screening. They were concerned about being judged or blamed by their healthcare providers. Another reason for why stigma matters, this is a study that we did when I was at the University of Wisconsin a long time ago. So in this study, we sent out surveys to 1,100 internists and family practice physicians. So this is in 2005, so things may very well have changed a lot. But we sent out a survey that had a cover letter and one of 4 case scenarios, and 672, close to 60% of these physicians responded. Half of the surveys were about a 53-year-old woman with a new diagnosis of a stage 1 breast cancer. Another half were about a 53-year-old woman with a new diagnosis of a stage 1 lung cancer. And the survey was designed so that, technically speaking, the answers should have been the same. And then they were also broken down into patients that did or didn't smoke. So again, physicians, without knowing it, were randomized to receive one of these scenarios. All of the answers are supposed to be the same. So this was a woman smoker with lung cancer, a woman non-smoker with lung cancer, woman smoker with breast cancer, and a woman non-smoker with breast cancer. The results, here are the percentage of physicians who felt that patients with early stage disease would have improved survival with chemotherapy. Breast cancer, lung cancer. Because stage 1 breast cancer and lung cancer both have improved survival, right? Stage 2 breast cancer and lung cancer studies have clearly shown that adjuvant chemotherapy improves survival for both breast and lung cancer. This is for the percentage of physicians who felt that patients with metastatic disease would have improved survival with chemotherapy, breast cancer and lung cancer. And we all know, as we heard today from Dr. Muhammad, that clearly patients with lung cancer benefit from treatment with metastatic disease. Another question that was kind of asked was the number of patients with advanced stage breast or lung cancer that either had a good performance status, meaning were feeling in relatively good health, or a poor performance status. And when these family practitioners, when would you refer them to a medical oncologist? Breast cancer, it didn't matter whether you had a good or a poor performance status. They all, a large proportion got referred to a medical oncologist. But look at lung cancer here. Now again, 2005, I'm sure things have changed, but clearly, at least in 2005, one of the big impacts of stigmatization was just who's going to get referred to see a medical oncologist. And then in this clinical scenario, the patient, originally has surgery and chemo, and then goes on to develop metastatic disease, and then goes on to develop severe pain. And one of the questions that was asked was, if your patients got severe pain, would you follow them? How often would you follow them? Every 1 to 2 weeks, every month, whatever. And for the question regarding every 1 to 2 weeks, 80% would follow their patients every 1 to 2 weeks with breast cancer, compared to about 70% with lung cancer. Again, statistically significant. Interestingly enough, didn't matter whether or not the patient smoked. Smokers and non-smokers were all the same. So just to summarize that, physicians were less likely to refer their patients with lung cancer to an oncologist than their patients with breast cancer. More physicians knew that chemotherapy improved survival in advanced breast cancer and in adjuvant disease. Breast cancer patients were more likely to be referred for further therapy, and interestingly, again, smoking status did not matter. So we've determined that yes, you can measure stigma, it's important. So what can we do to address it? And this is a much harder question, I think, and it's something I would really like this group to focus on. What have we learned from other diseases? Well, from breast cancer. So in the 60s, breast cancer was very much in the closet. I don't know if any of you remember that, but very much in the closet until the Komen organization was found. And it came out of the closet, at least in part, by such strategies as screening initiatives, educational campaigns, and popularization of the pink ribbon. AIDS, what have we learned from the AIDS community? That coordinated and persistent advocacy is necessary, increased awareness that the disease is treatable, and that patients are people and deserve respect, a large amount of using the media, social media, etc., to speak out and to share stories of experience and hope. And again, from Heidi Heyman, this is a table that summarizes her thoughts as to how stigma can be addressed, both on the individual patient level, on the clinician family level, and on a society level, in terms of prevention, screening, diagnosis and treatment, and survivorship. So can we do it? Can we actually reduce stigma? So we repeated that online survey from the Lung Cancer Initiative. We just repeated it. These results are going to be reported next month at the World Lung Cancer Conference. Technically, I'm not allowed to report them until then, but I'm going to report them anyway. So 2,000 patients in 2019 participated. The demographics were a little bit different. 57% females, 43% males, more males than last time. But otherwise, things were much the same. These are the results. Now that we're talking again about the explicit results, people with lung cancer should feel, or people with breast cancer should feel. And so this is a summary of the results. So in terms of people with cancer, this is lung cancer now, should feel ashamed. This is what the response was in 2012, 2019. Here is they should feel embarrassed, 2012, not at all in 2019. And they should feel hopeful. Well, in 2012, nobody thought they should feel hopeful. At least it is better now. And then these are the implicit scores. So you remember again, those are where they're measuring the reaction time to pressing the E or the I button. And for good, bad for lung cancer, again, in 2012, this is how many people felt, this is essentially how many people felt that lung cancer patients, who responded that, they responded slower to the scenario where lung cancer is good compared to lung cancer is bad. I hope that made sense. And this is 2019. It's gone down. Hope, despair, and mostly despair for lung cancer patients, has gone down, although it's not quite statistically significant. To be statistically significant, this number should be 0.05, but it's close. And shame, lung cancer patients feeling shame, again, also went down from 2012 to 2019. This goes into it in a little more detail. So now we're looking at lung cancer patients and whether you feel strongly that they should be hopeful or whether you feel strongly that they should be despairing. The 2012 is in the gray bar, and you can see in 2012 a lot of people felt strongly that lung cancer patients should be despairing. In 2019, it has started to shift. So in 2019, a fair number of people, a percentage of people, didn't feel one way or the other. I mean, I think the big take-home message here is that the curves have shifted. And same thing regarding whether you feel strongly that lung cancer and suitable words strongly go together versus lung cancer and shameful words strongly go together. Big shift here again in those red bars compared to the gray bars. So whereas in 2012, lots of people felt strongly that lung cancer and shameful words went together, in 2019, it's moving this way. And similarly with good and bad words. So just to summarize this portion of the study, in 2012, people associated lung cancer with negativity more than they did breast cancer, both with regards to self-reports and implicit beliefs. However, in 2019, this is improving. There's less shame and embarrassment with lung cancer and more association with hope compared to what it was in 2012. And of note, there were no changes in the breast cancer scores, and I think that's an important point. That this suggests that what is happening with lung cancer is specific to lung cancer and not necessarily to breast cancer. And the other thing is the literature apparently suggests that when this type of test is given in for other things, other diseases, other scenarios, they rarely change. So this lung cancer change is indeed significant and real. Why did it change? Well, again, I don't know, but some possibilities, and I suspect that we're going to hear and talk more about it later, is we have better treatments. And with better treatments, there's more optimism. And with more optimism, there's more research. And with more research, there's better treatments and more optimism, et cetera, et cetera, et cetera. Advocacy, for sure, I think, is a major impact factor here. It definitely puts a human face on the disease and promotes public awareness. One of the places, I mean, there's lots of places for advocacy, for sure. One of the places that I personally have noticed makes a difference is on committees that are charged with reviewing grants. And this can be at the National Cancer Institute, at the American Cancer Society, whatever. Nowadays, there's always a patient on the panel. And I think what that does, because many of these grants are written by PhDs who never see patients, what that does is it really puts a human face, makes it real for these scientists. That it's, you know, we're not just playing around here. There's really people who are depending on us doing good research. I think there's more survivors now to advocate where there were not 20 years ago. And again, I think we now have more social, I'm going to say this in quotes, socially acceptable faces. So in AIDS, one of the things that helped change AIDS was when children and mothers, not homosexuals, when children and mothers were found to get the virus through blood transfusions. Children and mothers were more socially acceptable, so to speak, at that time than homosexuals. And in lung cancer, we now have young, never smoking women. And again, we get back to this issue as to how we are going to balance the tension between smokers who feel that talking about never smokers stigmatizes them more versus the quote unquote more socially acceptable face. So, in conclusion, a lung cancer stigma is real, it can be measured. There are multiple factors as to why I think lung cancer is stigmatized. They did it to themselves and the unintended consequences of negative hard-hitting anti-tobacco ads, lots of consequences in terms of stigmatization, not only the psychosocial distress, delay in seeking care associated with lower treatment rates, reluctance to get screened, impact on never smokers, lower quality of care. It can be reduced, we've shown that, and I think, however, that we need more research to determine how we can reduce it even further. So with that, I thank you very much. It was great to be here. Again, a subject strong and dear to my heart, and again, good to reconnect. So thank you very much.